Welcome to the Novel Technology session. It's great to have you on board, and I'm delighted we're going to have a series of talks now from our industry partners, including Canon, Siemens, Philips and GE. So for our first talk, I'm delighted to introduce Erin Angel, PhD from Canon Medical Systems, who is going to talk about their vision of the future. Erin, over to you.
Cardiovascular disease, and specifically coronary artery disease, is a disease that progresses with time. We know that with the right lifestyle changes and with recent drug developments, we can slow or change the course of progression of this disease. And yet we focus much of our diagnosis on the symptoms of the disease, many of which manifest late in its life cycle, like ischemia. Half of these patients' first sign of disease is MI, or sudden cardiac death. What if we could do better? What if we could use imaging to actually view, quantify, and characterize atherosclerosis? What if we could provide a roadmap for each patient and establish outcome trajectories based on interventions? Recent scientific literature has demonstrated that visualization of coronary artery disease with cardiac CT holds great promise for the future of this disease. I'd like to propose that we've only just scratched the surface of what we can do to characterize the disease, and that in the next 5 years, we will see substantial developments in the visibility and characterization of coronary artery disease with CT. You have our commitment that as an imaging vendor, Canon Medical will continue to innovate meaningful solutions in this space. So what can you expect from Canon Cardiac CT? Well, you can expect multiple insights off of a single heartbeat acquisition with the Aquilion One wide area detector platform. You can also expect consistent results despite the variables introduced by each patient. And you can expect accessible solutions, so that whether you are imaging complex structural heart cases in a hospital setting or assessing chest pain in a cardiology outpatient setting, you can expect premium technologies that support your clinical needs for all patients. With the Aquilion One platform, one rotation is all it takes to cover the entire heart. You have the tools to triage your chest pain patients in a single exam with anatomical and functional information. You can image the coronaries, wall motion, ejection fraction, and functional analysis in one heartbeat. The table doesn't move, so the entire heart is captured in a single beat in less than 1/3 of a second. With this wide area detector CT platform, you can achieve anatomy, function, and physiology from a single study. This scanner design is ideally suited for supporting triple rule-out studies, structural heart studies, and complex cases. One of the key features you can expect from Canon CT is adaptability for consistency in results. As you think of your patient population, just think about what percentage of cases are not simple. What percentage of cases have a previous MI, a stent, a pacemaker, an ICD? Pacemaker and ICD leads cause metal artifact in cardiac CT, degrading image quality. But with metal artifact reduction for cardiac, they don't need to. 40% of the US population is medically obese. We know that obesity is a major risk factor to the development of cardiovascular disease. The percentage of bariatric cases in cardiac imaging is not small. You should expect a CT that can handle bariatric patients and still produce diagnostic image quality at a reasonable dose. Particularly in a hospital setting, managing steady heart rates in a patient population with high rates of cardiac disease can be challenging, but it doesn't need to be. Arrhythmia rejection combined with wide area detector, in other words, no table movement, means that the system can automatically adapt for an abnormal beat without the need to restart the study. You should expect a scanner that can still perform an advanced acquisition mode that automatically adapts for high heart rates. And you should expect the ability to scan multiple vascular territories to plan complex interventional procedures like TAVI or TAVR, where gating is needed through the heart and not through the abdominal aorta and femoral arteries. These patients often have impaired renal function, therefore it's important to reduce the contrast volume as much as possible. The minimum radiation dose should always be delivered. With 1-beat imaging, the whole heart temporal resolution is 137 milliseconds from a single heartbeat. And because the whole heart is captured in that rotation, there is no banding artifact or differences in appearance between rotations. And because the table doesn't move, the system can automatically adapt for an unsteady heart rate or arrhythmia without the need to stop the study or rescan. CMAR metal artifact reduction can be used to reduce artifact from metal during a cardiac study, and it can be applied before or after the study to best suit your workflow needs, improving visualization of implants and adjacent soft tissues for a clearer and more confident diagnosis. Cardiac adaptive motion correction compensates for motion within the coronaries. It enhances the visibility of coronary segments with motion and reduces cardiac motion for patients with higher heart rates. With this technology, you can expect diagnostic quality images at a low dose. This image was captured from a single heartbeat with no table motion. Even when the patient's heart rate is unpredictable, you can expect diagnostic quality with dose management. In this case, the patient's heart rate varied up to 96 beats per minute during the study. Because the patient was on an Aquilion 1, and because the table was not moving, the system detected the abnormal beat, waited for the next normal beat, and continued the study. No need to terminate the study, no need to re-inject contrast. Canon recently announced that all diagnostic CTs in the US are now AI-powered. This AI generation of CT uses AICE deep learning reconstruction. This new generation of iterative reconstruction is designed to distinguish true signal from noise to deliver sharp, clear, and distinct images at speed. Trained using vast amounts of high-quality image data, AICE provides enhanced anatomical resolution across the whole body, including the heart. As you can see with DLR, the enhanced signal and reduced noise brings visibility to a given study, which was not previously feasible. The patient in this example is in the early stages of coronary artery disease, but early detection of disease only enhances opportunity for prevention. And you can see the enhanced visibility with Deep Learning Recon. Because this DLR is trained with MBIR rather than filtered back projection, you can expect visibility of fine detail structures like stents in low-dose, low-noise images. There is no trade-off between using DLR and metal artifact reduction. DLR, Deep Learning Recon, works in conjunction with CMAR, metal artifact reduction, for consistency in image quality and adaptability for metal in the image. And now I'm proud to announce that Canon Medical has developed the world's first and only 1-beat spectral cardiac CT. The Aquilion 1 Prism Edition is a rapid KVP switching technology that works out to 16 centimeters, covering the whole heart in a single acquisition and producing spectral maps. As this is the first time we've seen spectral technology cover the whole heart from a single heartbeat, there is still opportunity to explore the full clinical value of this technology. But whether that be improved visualization of plaque characteristics or functional information from iodine quantification in the myocardium, we have developed a tool that can be used to explore the future of cardiac CT. And of course, one of the most important challenges of cardiac imaging is the ability to visualize small detail. If we are, as an industry, on a path to better visualizing and characterizing atherosclerosis, then you will need a tool that can help you visualize even the smallest spotty calcification. Canon Medical is at the forefront of innovation in this regard. The Precision CT system has twice the resolution of conventional CT and can be used in cardiac mode. The Precision CT is capable of resolving anatomy as small as 150 microns, providing CT image quality with resolution typically only seen in cath labs. The UHR detector is newly designed to provide more than twice the resolution when compared with today's other CT technology. We hope that you will visit us at the virtual Canon Medical booth at SCCT. And when you do, you will see something new. We are proud to announce here this year a new partnership between Canon Medical and Cleerly. Cleerly's mission is to create a new standard of care for coronary artery disease. And through this partnership, we bring access to this technology to further our commitment to bringing meaningful innovations to our customers. Thank you for taking the time to learn about Canon's CT technologies and how we are addressing your clinical needs now and into the future.
So having heard Erin, it's now time to move on to Siemens Healthineers, and I'm delighted to introduce Stefan Alzheimer, who is going to give us Siemens' vision of the future.
Hello from Germany. My name is Stefan Alzheimer from Siemens Healthineers, and in the next 12 minutes, I will share with you our vision and the trends we see in cardiac computed tomography. So the core topics for CT have been and will be, from our perspective, system innovation, creating the best possible images and data for further processing. Second, optimized workflow and automation. Third, increase the clinical value of CT in general, and a big focus on imaging in therapy, and all this powered by artificial intelligence in areas where it makes sense. So let's have a closer look at our vision of a smart CT empowered by artificial intelligence. So first step, scan automation. That consists of automated positioning using 3D sensors like our 3D camera, protocol guidance, finding the best protocol for each patient and clinical questions, and contrast guidance. As you know, we have had a 3D camera mounted on the ceiling for quite some time, and we will increasingly add value to that data and what we can do with that data. So we obtain color and depth information for every patient. We then can automatically detect the pose, body regions, and we can do what we call avatar fitting to find the isocenter to optimize the scan and also the dose. We can automatically then position the patient so the table moves to the ideal isocenter and the topogram start position. And we will do scan range indications based on landmarks, for example, the thorax. And publications have shown that using 3D information for positioning the patient can save up to 25% radiation dose. A publication published by NYU in 697 patients. In the future, we will work on organ level scan ranges, guidance for placement of ECG electrodes, for example, virtual fusion of prior scans, and augmented reality for interventional procedures. We have a product called My Exam Companion, which is basically a site-specific protocol guidance for CT. It is embedded within the default protocols, both at the tablet and the scanner console, and it offers more than 20 decision trees for routine and advanced clinical indications, especially also for cardiac CT. Let's have a look at contrast, one of the more complicated things and often carried out suboptimally. So we are working on a machine learning based on a large database of patient data to optimize also contrast injection protocols. How does that work? So we have input data, bolus tracking data, and based on a large algorithm database, the injection is done in an automatic and optimized fashion, as you can see here from a case from the University Hospital of Zurich in Switzerland. AI-supported image reconstruction. So as you know, iterative reconstruction has been a big success in CT, really lowering radiation dose to the patient. Unfortunately, with increasing noise reduction, you get very unnatural image impression and noise texture. So artificial intelligence can help here to really, at also high noise reduction levels, improve the natural impression of the images. And this is an example on the left-hand side, original dose with filtered back projection, then reduced dose to 1/3 with filtered back projection. And you can notice, of course, the significantly higher image noise. And then you can restore the image impression and noise level with AI-based deep learning reconstruction. And it almost looks like the original filtered back projection image at full dose. Assisted reading. So what we can do after the scan using AI algorithms, we can provide key images that are automatically sent to PACS. We can provide anatomically aligned views. We can provide curved reformats, and we can do automatic vessel tree unfolding. You can provide quantitative results, PACS ready, calcium scoring results, stenosis detection and grading, plaque detection and analysis in the future, and provide basically also indications of the relevance of a certain stenosis, all things that we've been working on and we will be able to provide in the future. So our product basically related to assisted reading and reporting is called AI Red Companion. So you have input data and then using a deep learning network basically to segment anatomical structures and provide the measurements and recognize abnormalities. And then you get key images that are automatically generated. You get automatic measurements that all can be automatically sent to a report. A report is generated and you can send everything automatically to PACS. That's the philosophy basically behind the AI Red Companions. We have already as a product the AI Red Companion Chest, which provides automated support of chest reading with automatic lung cancer screening, nodule detection, COPD analysis, emphysema quantification, and so on. And we are also working on a dedicated AI Red Companion for cardiac, providing then automatic calcium scoring and automatic quantitative coronary analysis. Back to system innovation. We've been working on the key component of a CT scanner, the detector system, for quite some time. So over 18 years now from basic research to a future final product. What is photon counting CT about? So this basically shows the schematics, how today's CT detectors work. It's a scintillator-based two-step conversion principle from X-rays into an electric signal. So first the X-rays are attenuated in the scintillator, and visible light is generated, and then the photodiode array converts the visible light into an electric current. It's a very robust technology, very good, very reliable, very dose efficient. However, two disadvantages: mainly, you lose the energy information of your X-rays in this two-step conversion process. That's the one disadvantage, and you need these septa in between your scintillator pixels. Second disadvantage, and that prevents you basically from going to higher resolution in your CT detector, because increasing the number of septa, increasing the number of pixels would significantly reduce the dose efficiency of the detector. On the other side, there are directly converting detectors. We work with cadmium telluride 1 crystals, also called photon counting detectors, because they can basically count each individual photon and at the same time measure its energy. So what advantages does that deliver? You can go to significantly smaller detector pixels without reducing dose efficiency. You can completely eliminate electronics noise of your detector. You can increase the contrast to noise ratio, or on the other hand, reduce radiation dose significantly by the ability to measure the energy of each individual quantum. And you have this intrinsic spectral sensitivity, so you can always get dual energy information and even measure more than 2 energy levels with these kinds of detectors. Let's have a look at some examples from early prototypes, showing at the same dose level basically higher detail because of the higher spatial resolution at the same dose level. Photon counting here on the left-hand side, and for comparison, our high-end product, the Somatom Force. Also stent imaging here. These prototypes that we've been working on don't have a cardiac scan mode yet. So all these are in vitro studies, but you can nicely show the difference in resolution in this 4mm stent. In the middle, traditional technology, energy integrating detector, and on the right-hand side, photon counting detector. So this is a very experimental study in a lamb heart. But nicely showing that with the increased spatial resolution of such CT detectors, you can actually visualize microvessels down to 20 micrometers here in this lamb heart. A study carried out at Linköping University, one of our collaboration partners in this area. You can completely eliminate, as I said, electronics noise, so you get very stable, robust CT numbers, increase how quantitative CT is and can be, especially useful and beneficial in all areas where you have high attenuation in obese patients, or you scan with very, very low dose values in screening applications, lung cancer screening, also calcium scoring scans, or in pediatric scans. For the first time, really, without any compromises, you can get full spatial and temporal resolution in cardiac scans combined with spectral information. So the new standard really will be monoenergetic imaging. So you can dynamically and interactively go through your monoenergetic data sets like you window today. You basically can scroll through the energy levels from 45 keV up to 190 keV. At the same time, you get immediately iodine maps, and you can always use the spectral information to remove calcifications from all structures in a very robust fashion. So the calcium removal aspect is shown here again. So in the middle, basically traditional approach, threshold based, and on the right-hand side, calcium removal using spectral information. So in every voxel, you can just remove the amount of calcium that is in that vessel and give you a clear view basically on the structures underneath. We have over 95 publications so far first concentrating on non-inferiority studies. So in humans, we were able to show that you can reach the high level of image quality that you're used to from high-end CT, and very soon also concentrating on additional benefits of the technology in various clinical applications. So to repeat, what can photon counting CT bring you as one example of system innovation? Higher resolution, no electronics noise anymore, better contrast to noise ratio by no downweighting anymore of lower energy quanta, and always intrinsic spectral sensitivity. So I hope I was able to show you in what areas we're active and where we see the future of cardiac CT particularly. And I'm really looking forward to seeing you again in person very soon. Okay, thank you very much for your attention.
So having heard from half of our partners so far, let's move on and hear what Philips Healthcare have got to say. And I'm delighted to introduce Mark Olszewski, who is going to again give us Philips' view of the future. Over to you.
Good morning, good afternoon, and good evening. My name is Mark Olszewski, and I'm with Philips Computed Tomography. Today, I'd like to talk to you more about spectral detector computed tomography and the new opportunities and future directions enabled for cardiovascular CT. With many years of experience under the belt now, we can see the benefits of spectral detector CT help us to deliver on the promise of multi-energy CT, moving CT from being just a valuable imaging modality to helping us to maximize the value of each of the photons that we utilize, expanding the range of patient cohorts and applications, and driving spectral certainty in every patient and every scan performed. By leveraging the spectral information that we gather from every exam using a detector-based methodology, we can increase the certainty with which we can identify incidental findings and characterize them, how we can respond to challenging scans, and even salvage suboptimal scans where injection timing may have been compromised. We can help to utilize those techniques to enhance how we handle demanding patient conditions, reduce the amount of injected contrast, and look to further enhance patient safety and the practice of ALARA. This carries over to cardiovascular CT and the current challenges that cardiac CT faces in its application. It opens new opportunities by utilizing the spectral information contained within images gathered with spectral detection systems. We can look to see how we can reduce the effective blooming of high-density objects like calcifications and stents, look to see how we can reduce the effective beam hardening artifacts that affect our assessment of the myocardium, look at how we can better manage patients with poor GFR and how to reduce the iodine load for coronary and TAVI scans, look to characterize non-calcified plaques and avoid the conundrum that Hounsfield unit overlap provides when trying to assess fatty versus fibrous lesions, looking to enhance our ability to assess complex cardiac morphology, looking at how we can enhance the assessment of clot versus slow flow or stasis in the left atrial appendage, and looking how we can make better use of the information contained within the scans to assess whether tissue is viable or has scarred. Of course, the first example is one that may be familiar to us all, assessing whether there is in-stent restenosis present in the context of a heavily bloomed coronary stent. On the left here, we can see that in conventional CT, this makes the assessment of the proximal area of the lesion particularly difficult. Looking at the spectral results, however, and looking at an iodine map gives us the ability to avoid that blooming effect, to determine that there is in fact in-stent restenosis occurring at the proximal area of that stent, and also have the ability to quantify specifically the amount of iodine at every location along the pathway of the lumen, making it much easier to assess the condition for the patient. And this is part of the natural ability of a spectral detector CT that acquires data at the same time and space and allows us to use the full capabilities of the scanner for coronary assessment. We can also take a similar approach when evaluating the myocardial hypoperfusion in the patient seen here. In the conventional image at the upper left, we can not discern whether there is any hypoperfusion in the myocardium. And in fact, many would say that the myocardium here presents as pretty normal. However, if we look at the spectral results of the iodine map in the lower left, you can particularly notice the hypoperfusion present in the myocardium. And that can be reconfirmed by also looking at the effective atomic number maps that are overlaid on the conventional image, or the effective atomic map itself, where we can look at the quantification of iodine in different ways. And in each of these maps, we can see and measure the correlation with the conventional angiogram on the right, demonstrating that in fact there was an occlusion, the first diagonal. As we look at challenging patient populations, performing coronary CTA with reduced contrast load is important when dealing with populations that may be less tolerant to injected contrast, such as this 70-year-old female who had a history of chest pain and glomerular nephropathy with a GFR of only 48. By utilizing the ability of spectral detector CT to be more sensitive to iodine, this image was able to be acquired with only 7 milliliters of iodinated contrast, and also allow a contrast reserve to be set aside for the next day's surgery without increasing the load to the patient. And we see this effect through multiple studies demonstrating the ability to reduce injected contrast consistently by 50 to 60%, even in addition to these extreme cases where we can show single-digit milliliters of injected contrast. And that's across a number of different clinical indications. We can also take the iodine analysis one step further and look at how it can help us to measure and predict the potential outcome of PCI. In a study presented by Lee et al. In radiology cardiothoracic imaging last year, they demonstrated the ability to use spectral coronary computed tomography angiography in the identification and characterization of chronic total occlusion. And while PCI is common in those patients, the outcomes can vary. What the study demonstrated was that iodine-based spectral results can provide quantification of contrast in the coronaries and help to predict the outcome of those patients and change patient management, and also demonstrated the potential economic impact of saving an intervention along with the PCI for those patients. Along the same lines, we can look at how we can quantify extracellular volume. This is a technique typically used with MRI to calculate maps that allow the evaluation of cardiomyopathies. The spectral results, both virtual non-contrast and iodine maps, allow the calculation of extracellular volume from a single scan with CT now. Demonstrated as was presented by Oda et al. In 2019. That three-dimensional color mapping and quantitative iodine mapping of the myocardium allows us to look at the extracellular volume as an indicator of fibrosis, and is really useful in that we can assess both the coronaries and the extracellular volume then from a single scan. As we look to the future then, what more can we do with spectral detector CT? In one sense, we can look at being more quantitative and more precise about the characterization of materials within the image. Spectral fingerprinting is a technique that is under development today to look at how we can be more precise in material characterization, moving from a one-dimensional Hounsfield scale to not just look at low or high energy or iodine maps as we've demonstrated over the past few images, but by calibrating the Compton and photoelectric scatter effects to preside and present to us unique so-called zip codes, if you will, of the Compton and photoelectric pairing, calibrated against databases like those in the NIST database, then allowing us to create maps of not just iodine or effective atomic number, but maps of quantification of the density of various tissues and ratios of tissues within the image. This can then be used, for instance, in this abdominal CT example, looking at a complex lesion that would be very difficult to assess under conventional CT, and we can map those against, for instance, water, fat, bile, and cholesterol, the clusters within the photoelectric and Compton scatter plots. And what you see on the right then is by mapping that and overlaying the characterization and concentration of materials back onto the conventional CT image, you can demonstrate a quite large cholesterol stone in the image here that would not be readily apparent and is very now easy to both quantify and to measure. That same technique can now be used to assess, for instance, the automatic assessment of paracoronary fat. We know that it's an opportunity to look at a visualization of markers of inflammation around the coronaries, and it may be a very, very important technique moving forward to assess coronary risk stratification. And here we can use the techniques we've shown with fingerprinting and with automatic assessment to pull that information out of the spectral data sets and give us an enhanced vision of what is happening with each patient in the area around the vessel. And of course, our next step, starting first with spectral detector CT and demonstrating many of the benefits we saw today, we're now also taking the next steps by looking at the world's very first photon counting cardiac CT scans, such as this one, which is the first ever performed in Lyon, France, looking at the exquisite detail of not just the coronary arteries, looking at the enhanced spatial resolution, the extremely low dose that can be acquired with, but also seeing the detail in the same image from the lungs and looking at the very, very exquisite detail there and demonstrating the potential when coupled with the spectral results that we saw earlier to go to the next generation of CT scanning and open up new doors and towards both morphological and functional assessment, as well as the opportunities to look at targeted tracers and targeted theranostic applications where we can tag tissues and take us to the next era of CT. With that, I hope that I've stimulated some thoughts in your mind and that you're going to be able to partake in the live question and answer session coming up in just a few moments. I thank you for your time and attention. Have a good day.
And last, but by no means least, it's a pleasure to introduce Saad Sirohi, who's going to give us GE's vision of the future and where they see novel technologies going forwards.
Hi, this is Saad Sirohi. I lead the advanced apps and digital business segment globally for our CT business. That's part of our MICT organization in GE Healthcare. I'd like to talk to you about the future of cardiac CT. Before we get into the main topic for today, I'd like to, as we know, cardiac CT is a very useful diagnostic tool for diagnostic workup of many types of cardiac diseases, including the anatomical diseases like coronary artery disease, functional diseases to assess ejection fraction, assessment of myocardial perfusion using dynamic acquisition, as well as looking at the structural heart diseases that could be part of either aortic valve disease or mitral valve disease as part of planning for TAVI workup. The topic that I want to talk about and where we see the CT diagnostic management going in the future is really the environment that we are sitting in right now. We know that coronary artery disease diagnosis accuracy and patient risk assessment do need to be improved, right? This is an active area where there's a lot of activity, research, clinical trials that have been in place. Now we know that cardiac CT is proven to accurately diagnose coronary artery disease. It's also proven to streamline the downstream investigations and the treatments that triaging of cardiac disease provides in the management of the patient. Very recently, we've seen guidelines change, recommendations from NICE about using cardiac CT as the first line of diagnostic test. The ESC, of course, introduced the same guidelines for coronary CTA as the initial test for diagnosing coronary artery disease. And then we are also aware of the US ACC updates recommendation to consider cardiac CTA as an evaluation for stable coronary artery disease. So this is expected today. What we anticipate with this is that there will be a change in the volume of cardiac CT procedures happening. And so the biggest thing that we want to look at is how do we make that transition and the increased volume of cardiac CT examinations and their diagnosis and their assessment become a more streamlined and improve the workflow so that it doesn't it's not just linked to one specific specialist technologist who's doing the cardiac scan, and then the very specialist post-processing application. So it becomes much more of a routine procedure. In that, when we look at the environment of this of a CT scan, the CT scan by itself is not the only thing that's involved in the entire patient workup. So there is the ordering element, protocoling of that patient, to which scan they need to go to. Once the patient gets to the scanner, how do you position that patient appropriately? How do you define what areas need to be scanned? What are the specific scanning protocols to be used? What are the things that may be extenuating circumstances for that particular patient, whether it's increased heart rate, change in heart rate. And then, of course, once those images are produced, you want to make sure that they are reconstructed for the best quality of the image, and then processed so that they can be presented to the physician, the radiologist, and then the physician who's in charge of the patient. So it's an entire ecosystem, and what we feel is that even though CT has become a Swiss Army knife, and it really, you don't really spend a lot of time on the scan itself, we know that the efficiency needs to be improved at the entire ecosystem, and that's really what's driving where we are going in CT, especially very pertinently for the workflow in cardiac CT. So as we look at cardiac CT, we see that the environment that we want to operate in is to automatically figure out the right cardiac protocol that needs to be selected for the patient coming in. And this will help in the triaging at the scanner, so that using machine learning, we have technologies that talk about intelligent protocoling that will select the right cardiac protocol that will improve that whole scanning process. We want to also automate how to position the patient on the table, so that both the patient is centered, but also the right anatomy is pre-positioned so that they can appropriately scan what needs to be scanned, in this particular case, the heart. As we go into the scanning process, we want to automate all of the scan parameters. Now, this is where it's worthwhile to note that we have many different technologies in place on the scanning piece that can be configured to detect and avoid any kind of erratic beats, ectopic beats, any of those components that could make scanning a patient more of a challenge when the patient is on the table. Plus, together with the single beat acquisition mode on our CT scanners, this allows us a robust and comprehensive exam in this instance that the patient has been prepped onto the table. So you don't have to worry about repeat scans. Now, in addition to that, we are also looking at how do you make sure that the image quality is really enhanced when you talk about the exam. So whether it's a small patient or a large patient, we want to make sure that the images and the coronary arteries that result from those images are of pristine quality, and at the lowest possible dose that's possible. So that's really the key areas that we focus when we're talking about the scan. Now, once the scan has been done, we've got image reconstruction engines that, like True Fidelity, that provide exquisite image quality at the lowest possible dose of the acquisition. Then it translates into what do you do with those images that have been scanned, right? And this is where you go into a post-processing workup, where we start looking at how do you make sure, even though we've got very high acquisition speed, coronary motion is a big challenge, and even the whole heart motion is a big challenge. So we've got technologies that reduce the motion that is still present even after acquisition. So like snapshot freeze will do automated whole heart motion correction. And then we can send them through to the post-processing and automate that process as well. How do we actually take it through and assess what's going on with the patient's coronaries? Here is an example of what a future workflow really would look like, right? It's the scanner, as I mentioned. Patient comes in, you know exactly which protocol to scan. The individual variations of that patient will trigger compensation on the scanner at the acquisition mode. We will generate a whole heart motion corrected exam. These will then flow into a post-processing where all of the coronary arteries will be fully tracked, labeled, presented in a view that the physicians can really assess each one of those coronary arteries independently. These outputs can then go and feed. If there is a finding in the future, we can go into what do we need to do with that particular finding. How, is a finding is a constriction or a blockage in the coronaries? What are its downfield effects? So we're working on technologies that can help assess that, like fractional flow reserve components. In addition to that, if there is a finding of a plaque, what is that plaque analysis? What's the composition of the plaques? We've got tools that are in place that can work on that. In addition to that, if we also have the ability to do dynamic acquisitions, as I mentioned before, and really look at the myocardial perfusion using blood flow analysis at the myocardial level. So with all of these technologies, we feel that we are well positioned to really streamline the workflow as we see an increase of volume in cardiac CT coming in with the new guidelines that are in place. And this really sets up with the vision that we have of a flexible and simplified reading, automating the acquisition, automating the post-processing, and then allowing the review and report to be either sent to wherever the physician wants it or have access to it from anywhere in the hospital network to the true data for really streamlining the whole analysis of data. And this really fits in with our overall vision of CT, which is really reaching the right diagnosis effortlessly. And cardiac CT is a key important part of it, but we also believe that this recipe that we're talking about here is relevant for all of the different conditions that a patient comes in to actually get scanned. And we continually improve that through new added techniques like deep learning and AI. And we believe in bringing the latest and greatest technology back to our customers. And we even have an innovation in the business model that we go with that's really part of smart subscription offering that we provide. And this really is a great opportunity for a joint collaboration with physicians and with the industry to come to a solution that really is addressing one of the biggest diseases that has a huge impact to the globe, and that's cardiac disease. Thank you.